Hi, my name is Dr. Ramsey Abadir. I work with American Endovascular and Amputation Prevention, and going to present a critical limb ischemia case today that is a little bit unusual. Patient is an 82-year-old male patient who is presenting with painful blistering ulcerations on the anterior surface of his left calf that have been present for 3 to 4 months prior to presentation, and these have persisted despite aggressive wound care. He also complains of tiredness and heaviness in his legs on ambulation, left a little bit worse than the right. He has a history of peripheral vascular disease with some sort of stent being placed in the left leg, and there are no distal pulses palpable in either lower extremity. His past medical history is significant for coronary artery disease, and he's had a previous bypass as well as coronary stents placed. Also hypertension, atrial fibrillation, and peripheral vascular disease. His social history includes a previous history of smoking, which he stopped at the time of his bypass grafting. Medications, he's on a beta blocker, metoprolol, as well as lisinopril and Coumadin for his atrial fibrillation. So, how do we evaluate this patient? First of all, we noticed one omission in his medications in that most patients of this status should be on some sort of statin therapy. So we'd like to evaluate his lipid profile and probably initiate statin therapy. In addition, Coumadin has fallen out of favor for treatment of atrial fibrillation, and it has been shown to be beneficial in peripheral arterial disease. So we'd like to discuss his cardiologist, whether we can switch those medications around. Lastly, we'll get an arterial duplex to evaluate the functional status of his leg and to determine any levels of obstruction. Reviewing that study demonstrated about 75% stenosis in his superficial femoral artery, as well as an occluded anterior tibial artery. Biphasic flow is maintained down into the foot. So once that information is together, we can proceed to treatment with angiography and angioplasty, atherectomy, or stent placement as needed. Here's some images from the study. The stenosis in the proximal superficial femoral artery was confirmed, and that was fairly easily treated with atherectomy and drug-coated balloon angioplasty. More difficult is his tibial vascular disease. Here is an example of a normal angiogram of the legs, which shows the popliteal artery giving rise to the 3 tibial vessels as they course through the calf. And on the right-hand side of your screen, you can appreciate that the patient's anterior tibial artery is very irregular, and eventually it closes in the middle of the calf and doesn't supply any flow to the anterior calf as well as distally. So the treatment was to perform atherectomy of the anterior tibial artery all the way down to the foot, as well as angioplasty. And these are the results of the procedure. These are the already visualized pre-procedural pictures. And following angioplasty, you can see there's improved inflow to the anterior tibial artery proximally, as well as better outflow down into the foot and increased perfusion of that mid portion where all the ulcers are on his leg. So following him after the procedure, over the course of approximately 3 months from the procedure, you can see his initial presentation in June. His procedure was performed in September. In October, he's had substantial improvement, although he had his bandage on a little tight, as you can see. And then by December, he's really substantially improved almost all the areas, a few small little residual ulcerations at the top of the calf, but you can see much decreased hyperemia of the leg, decreased edema, and overall continued healing. He also reports that the pain in the leg was significantly improved. End result of this is that most people associate peripheral arterial disease with gangrene and ulceration of the toes. However, it can present in unusual situations higher up in the leg, such as in this patient. And any patient who has ulcerations and significant risk factors, including hypertension, diabetes, smoking, or a family history of PAD, should have that included in their differential. Of course, for all these patients, we like to maximize their medical management with statins and antiplatelet therapy to improve the status of their atherosclerotic disease. And it's important to realize that even for small vessels that previously would not be treated and considered unsalvageable, there are now available complex endovascular interventions which can restore perfusion and heal up previously not treatable lesions. Thank you very much for paying attention to this presentation. I'd like you to remember that here at American Endovascular, at our various sites, we are eager to treat patients with complex vascular disease that other vascular interventionalists may have abandoned and said were unsalvageable. At least 50% of those cases, we can usually obtain positive results. Thank you for your attention.